coming tonight. My name is Dr. Sarah Cole. I'm an orthopaedic surgeon based in Far North Queensland, and tonight is part of our long-standing series on whatever people want to talk about. And tonight, I think we've got a really important topic. We're talking about exercise and oncology and the relationship, and the most critical aspect, I think, of this talk tonight, which I'm hoping to hear about, is improvements in quality of life and ... survival, which I think is just really exciting. Go ahead, John.
Lovely. I'd just like to say to Dr. Cole, thank you very much for the opportunity to let you present. Quickly about myself, I've been working in mental healthcare for about 6 years now. Developed a bit of interest in exercise and oncology, have a fair bit of oncology stuff in my family, grandfathers, father, myself, things like that. So it's definitely a very interesting topic. But I definitely think up in the far north here, the need for some exercise intervention probably isn't as widely known. So I definitely think tonight should hopefully help encourage, getting the word out that things we can do are actually going to benefit the oncology population, definitely. So this is what our overview will be today. We'll sort out prevalence of cancer, impact and challenges, obviously the role of us exercise professionals ourselves, overview of the phases of rehab, treatments, side effects, obviously the guidelines and considerations when obviously doing the exercise and treatment. And we'll finish off with a bit of a study as well. So the cancer burden or current cancer burden in Australia. So as you can see here, I'll just wave it, ladies. So estimated number of cancer diagnosed in 2022. So this is just in Australia. These are Australian statistics. 162,000, obviously males and more females. Okay, prevalence. And the estimated number of deaths as well. So 50,000, again, males more than females. Okay, so the size of the problem, 44 million cancer survivors worldwide. Okay, at this point, 18.1 million diagnoses every year. So pretty significant. A few reasons for that. Obviously, screening is a lot better these days. Okay, we're picking things up earlier. Obviously, before, someone may have been picked up more end stage, particularly when they've been dying already, so obviously it's getting picked up earlier, and obviously the survival rate is more because treatment is getting utilised earlier, and then obviously in turn, the survival rate is increased as well. Common cancer types. Now, as we can see here, this is again from Australia. So prostate cancer and breast cancer, obviously the two main ones here. So male, female, as we can see. All right. Other ones that we can see here, colorectal, lungs, vital, stomach. But again, they're pretty similar between male and female. All right. But particularly there, prostate cancer and breast cancer, they're the huge ones, particularly up here in the far north as well. Particularly if you go to any of the oncology services currently, it would be a large majority of prostate and breast cancer. Okay. Huge. What causes it and risk factors? So as we can see here, a few different causes. So obviously cancer itself is just cells that aren't doing programmed cell death. Okay, so essentially what happens is they're programmed to die, they do not, they start proliferating, all right, and obviously then they start growing uncontrollably, and obviously that in turn develops cancer. Okay, so genetic factors, cell mutation, family history, environmental exposures, radiation, chemicals. Obviously, a big one up here for far north, all the farms we have around here, particularly the older generations, using all these chemicals on their foods, the sugar cane, things like that. PPE probably wasn't a real common use thing back in the day as well. So as we can see, this is probably why we're starting to see a lot more being diagnosed. Chronic inflammation and infections as well, damaging its DNA, which again is increasing this proliferation. And then we've got lifestyle factors. So this is a huge thing that us as exercise professionals can help with. Smoking, sedentary behaviour, inadequate, unhealthy diet are just some common things again that can really sort of increase your risk. Physical challenges. So this lady on the right here, it was a lady that did a bit of a promo thing called Under the Red Dress. So as you can see here, she looks quite like a nice beautiful lady on the left side, but you wouldn't even know what was going on. The red dress. So as you can see here, multiple surgeries, all these type of things, drains, etc., etc. Again, this is just some physical challenges that people with cancer obviously experience. So Fatigue, pain and scarring, obviously post-op, weakness and deconditioning, sexual dysfunction, neurological impairments. But a big thing here is the changes in appearance and the loss of independence. Obviously, a big thing, is the looks, our appearance, Cancer is, not just all about, the systemic type thing, but, on the outside as well, physical challenges, very, very challenging, as you can see here. Psychological, this is another big one. So obviously after someone's been diagnosed with cancer, they're going to have a lot of anxiety and depression, all right? Post-traumatic stress, fearing of relapse, confidence and self-esteem is going to be affected as well. They're not going to want to do things in fear of exacerbating, their symptoms or any other type of signs that they might be experiencing. But again, that psychological challenges is a huge factor here. So as we'll talk about a little bit later, the need for interventions into this is very, very key as well. Okay. And then we have social challenges, isolation, loneliness. A lot of these things, obviously it's that individual. So, loneliness and social isolation is a huge thing here as well. Sometimes these people think that, it's all about their own journey, no one else can help with them, etc., etc. But of course, then unemployment starts to happen. If you're too unwell to go to work, relationship challenges another big thing here as well. Significant others, all right, and occupational and financial disadvantages. So imagine if you're going through, radium, chemo, surgery. If you're not able to work, you're not covered, you don't have an income coming in. Obviously, this can really start to, become a bit of a disadvantage as well. Long-term health challenges. Now, this is where we start to get into some challenges that obviously aren't just, the cancer itself. So, as we can see here, cardiovascular disease, huge in this population. The recurrence of cancer itself. A lot of people obviously, they beat cancer, so to speak. It comes back up years later, for instance. Osteoporosis, functional decline, metabolic syndromes, as you can see here. So it's not just a case of you be diagnosed with cancer and you're fighting the cancer. It obviously increases the risk of further comorbidities and complications as well here. How can exercise help? All right, the big thing. Studies have shown can assist with the prevention of 7 common cancers, as you can see here. Okay, this is prevention, obviously. Okay. The reason being increases your baseline fitness, functional reserve. Okay, now this can obviously help with preparation for the treatment itself, reducing the risk of those comorbidities, which we just spoke about as well. All right, reducing the risk of recurrence. Despite the research out there suggesting that this is beneficial, as you can see here, participation in regular physical activity is less than 50% for someone that's been diagnosed with cancer. So, as you can imagine, over half the population aren't even utilising, these services. So, as you can imagine, the outcomes may not be so favourable, obviously, for these people. Okay. Now, this is the role of exercise in the cancer continuum. So, this is a good little diagram here, just showing, the entire journey, so to speak, with someone that's been diagnosed. So, obviously, we've got, the prehab, which is what we'll talk about shortly. The prevention. Prevention is obviously better than cure, as we all know. But they go and they're screened, detection, they're diagnosed. Okay. As soon as we are diagnosed, or as soon as someone's diagnosed, that is when exercise intervention should be straight away. All right. So obviously, as they go through the pre-treatment, get you ready. Okay. You go through the treatment itself, get into that survivorship phase, and then obviously towards palliation. Now, very key point to note here, it doesn't matter what phase someone is through their journey here, exercise can always be an intervention to be utilised. All right? Whether someone's just been diagnosed, whether someone's palliative, exercise is always going to be beneficial. Okay? Obviously, with the end goal here of improving quality of life. Okay? Very, very simple. Okay, so prehab and rehab intervention. So what this should actually be. So as we all know, multidisciplinary approach. Okay, so this is where as soon as someone has been diagnosed or as soon as you get a referral, whether or not you're an OT, physio, exercise physiologist, you need to make those appropriate referrals to the health professionals. Okay, so OT, dietitian, obviously we want to make sure that their diet is adequate, okay? Psychology input is obviously a big thing as well. As I mentioned previously before there, 2 in 5 are affected by depression after their diagnosis of cancer. 2 in 5, quite a large number. Mortality risk is increased by 20% in patients with prior depression. So again, 1 in 5. So huge thing here, get psych input straight away. And then obviously you need close contact with your treating oncologist and the oncology nurses as well. So as you can see here, it's a huge team, all right? Working as a team will significantly improve a patient's outcomes, all right? And obviously myself being an exercise physiologist, we want to commence that exercise rehab ASAP, as soon as possible. This is a good little flow chart here. Now, I didn't want to include, heaps of charts and, all different data and graphs, etc. But I definitely think this is a good one. It just shows, generally where you can have intervention of rehab and what it'll actually be in terms of benefits. So someone here is diagnosed with cancer. As you can see, if they do some sort of rehab, okay, we build up a functional baseline rather than someone that doesn't stay the same. As soon as we get then into the treatment phase, obviously, going through treatment, it's going to multiple bouts. So more than likely going to decline functionally. However, if you're declining functionally from the top here, coming down, obviously it's much, much better your outcomes rather than if you haven't done rehab. And then obviously after they've done the treatment, you're in the recovery phase, you do post-op or post-surgical rehab, etc. And continue this trend, building that functional baseline back up. Someone that does not obviously continues to decline. Okay, so I thought that was a really good one to include here. 4 domains of optimal rehab. Okay, so these are the 4 main ones that we try and look for. Preventative, okay? So essentially this is reducing unnecessary suffering to the patient, whether this be, treatment-related side effects, the treatment itself, things like that. Therapy and education is commenced to prevent functional decline, okay? Straight on, right? Very, very important. Exercise in other studies have shown to reduce post-op complications in high-risk patients scheduled for some elective colon resection surgery. So, as you can imagine here, we're just decreasing the risk of, unnecessary burden, etc., etc. Restorative, this isn't only just for patients with physical impairments and disability, this goes for everyone. Restoring that quality of life, getting them back to the baseline where they should be, and obviously working towards their individualised goals as well. Very, very important. Now, supportive, this again is a big one here as well. Providing reassurance and support. You can imagine someone's pretty vulnerable after being diagnosed with cancer. Okay, so just providing them that, look, things are going to be okay, putting these interventions in early, it's going to get someone in a better mind state. And as we all know, before rehab, the better psychologically and physically we work together, generally the better the outcome's going to be as well. And this again just increases their self-care and efficacy. They're not just relying on the treatment and the doctors and the exercise professionals. They're taking charge of their own journey as well, which is very important. And palliative, okay? This one here as well, just maintaining independence and enjoyment of life. Okay? Obviously, you're not going to probably be getting someone in the gym, 3 days a week, 4 days a week at this stage. It's just a case of keeping them as functional as possible to do the things they enjoy to do. Right? Giving them the best quality of life, making sure they enjoy their time, and not dragging things out and making sure that they're keeping their function as long as possible. It's really the key here as well. Okay. The phases of rehab itself. Rightio. Rehab, as we've just mentioned, time between diagnosis and treatment. This is where the exercise is so important. Reducing the incidence or severity of future impairments, okay, and establishing a baseline here. So obviously we want to do some exercise testing at this point, get a bit of a baseline as to where someone was at. That way in turn, when you retest this, during the next few phases, you can see sort of where they were at baseline and try and aim for that once you've, commenced your rehab. Okay, so rehab, as we can see here as well, post-op phase, aid in recovery from the cancer surgical intervention. So the key goals we're looking for here, restoring range of motion, strength and function. Now, again, let's use breast cancer as an example. Someone that has a mastectomy or whatever it may be. We want to get this range of motion back as soon as possible. Okay, obviously they've got drains in, and they may have had lymph nodes dissected or removed. So again, just sort of watching out for some common side effects such as lymphedema, things like that are the key at this point. Okay, treatment phase itself. So improving the tolerance to treatment. Okay, obviously if we've got a more functional reserve, that way when the treatment starts, you've got a little bit more reserve before it knocks you down from the treatment. Okay, and obviously reducing the side effects itself. So essentially it's just helped to improve the completion rates, particularly with chemo. It's also proposed in some studies that exercise helps deliver increased blood flow to the tumour itself. So obviously we know with exercise, we utilise our blood flow, our oxygen and our transport and things like that a lot better. So the idea is that obviously the tumour and the cancer itself needs blood and nutrients to grow. The idea is that if it gets more blood flow, the chemo can then attack the tumour a lot better, so to speak. Again, this is just what some studies have said. Random controlled trials of aerobic exercise during adjuvant chemotherapy demonstrates the preservation of or improvement in cardiovascular fitness. All right, so as you can see there as well, exercise, it's just really trying to reduce the symptom burden. Survivorship phase, continued rehab with a structured and guided routine, and obviously hopefully reducing the risk of comorbidities and the recurrence of cancer itself. And we're just going to briefly touch on the common cancer treatments as well. Now, of course, this whole topic of oncology, we could talk an hour just chemotherapy itself. I've just sort of chosen to do a very broad overview, making sure we understand what chemo is, radiation, side effects, but more importantly as well, the exercise interventions and how they can help. So kept it pretty broad, but we'll just touch over these here now. So surgical intervention itself. So it's usually the primary treatment. Obviously someone, is diagnosed with, again, say breast cancer, or it might be a tumour, in some part of their body. So the idea is to try and completely excise it, really trying to remove as much as possible. That way, in turn, we're reducing the risk of reoccurrence and things like that. Side effects, obviously, post-op pain is a big thing here. Impaired joint range of motion, as we've already mentioned, lymphedema, fatigue, and depression. All right, so again, all these type of things, as you'll soon sort of find out, we'll elaborate very shortly, they do work in with whatever treatment that you have. Okay, so that's surgical treatment. Chemotherapy, which I'm sure we're all familiar with, everyone knows what chemo is. Even to someone that's not in the medical field, they know what chemotherapy is. It's just a classic treatment of cancer. All right. So essentially, it's systemic therapy, obviously, to target those cancerous cells. So the big thing here is that these cells, as they're rapidly dividing, the chemotherapy really is just trying to kill those cells. Problem is, as you can imagine, it's non-targeted treatments because it's systemic. So it doesn't discriminate between healthy cells and cancer cells. It attacks all those cells. All right. So usually, obviously, injected into a vein, under the skin, pharmaceutically as well. And just to note here, just some common treatment cycles. So when someone, or if you read somewhere where it says neoadjuvant chemotherapy, it's usually pre-surgery or pre-treatment. Okay, the main treatment, I should say. It's essentially to try and reduce the size of the tumour, to try and shrink it. Obviously, then in turn, when you do the surgery, they're not having to take more margin out. Okay, obviously, there's less to take out. Obviously, then less complications with surgery, hopefully, and better outcomes as well. Adjuvant. So this is obviously then post-surgery, because they're trying to get a good margin around the tumour itself. That may not always be the case. There may still be some remnants left there. So they might do some, post-surgery chemotherapy just to try and kill off the remaining cancer cells that might be present, and palliative chemo. So this is essentially, definitely, if someone's got, stage 4 metastatic cancer, it's really just to try and reduce, the continual spread and burden that the cancer will have. So essentially, they will be on that until the cancer stops responding to it, or they get toxicity. Okay. So again, these are just some chemotherapy class and drug types here. Now, I couldn't get this particular one in colour. I just thought it was a really good one just to point out the different classes here, okay? And obviously then the different types of chemotherapy they use for the different cancers as well. So probably big things to note, particularly for us as exercise therapists. Breast cancer, obviously then hematological and testicular, bladder, lung, things like that, prostate. So big things are your taxanes, your vinca alkaloids, and the platinum-based agents. They're probably the three key things that I would say to you. Get a little bit more familiar with because we'll chat about that a little bit later. But again, as you can see, and for someone that hasn't really investigated too much into chemo, you just think of chemotherapy, but in reality, there's a whole list of different agents they use depending on the cancer itself. So it's very important to know which one they use. And side effects. All right, classic side effects here: fatigue, cardiotoxicity, and peripheral neuropathy. As you can see here, quite a large list. All right, I've chosen to focus on those three bold ones, which will elaborate a little bit more. Obviously, I think in terms of being exercise professionals, it's probably something that we need to focus on a little bit more or understand. But as you can see here, it's not just a case of they're fatigued and they're tired. There's a whole list of things. Okay, so really the big thing is when you're treating or seeing someone with cancer, really delve in deeper as to what sort of side effects that they have. We have radiotherapy, radiation. So external beam radiation therapy is a traditional method. I'm sure that some of you would know. We have the Icon Cancer Centre down here. Essentially, if someone has cancer, a radiation therapist will design a bit of a program for them. Put them into the external beam, and it shoots a beam of radiation at the cancer itself. Okay, so essentially the main goal here is to deprive the cancer cells of their potential to divide. Right, pretty self-explanatory. Two other things that may not be so common is brachytherapy. Essentially, that is injected radiation into the tumour site itself, and then obviously all these little the brachytherapy that just it's injected straight there and then essentially just dissolved around the tumour, provides radiation that way. But you can also take it with radiopharmaceuticals as well. You'll take a particular drug and obviously then it will attack the actual cancer cells itself. Okay. So as you can see, it damages the DNA and it's commonly used with other treatments as well. Someone might be, having chemotherapy, radiation at the same time. Obviously, as you can see here as well, it may be utilised to try and shrink that tumour pre-surgery as well, again, to try and reduce the margin they need to take out. Big things here, side effects again as well. Short-term, fatigue, rash, hair loss, diarrhoea. Long-term for us, lymphedema, cardiac toxicity, lung fibrosis. Particularly if someone's getting radiation on their lungs, as you can imagine, it's damaging the cells around it. Okay. So obviously the big thing is here, obviously if we're damaging, your lungs, their O2 transporters are going to be efficient, therefore someone's cardiovascular fitness probably isn't going to be as good as well. Okay? Quick little story here actually that I was told, particularly with some vascular surgeons, because they do a lot of radium and x-rays and things like that, etc., they'll obviously use lead to prevent radiation exposure. However, I was told that a particular surgeon has no hair on his leg from the back, here down, both legs. Reason being is that the lead only goes down so far. Obviously, he's being exposed to the radiation itself, and it's actually killing off hair loss in that site. Just something interesting. So you can imagine this particular surgeon and maybe other vascular surgeons are being exposed to more doses of radiation than maybe they should be as well. Just something to note. Hormone therapy, this is another big thing as well. So obviously it targets specific cancers that are driven by hormones. So your classic ones here, prostate, breast, thyroid, okay? Difference between this treatment, it usually goes on for an extended period of time, 5 to 10 years plus, okay? Also used in combination of other treatments. There's some examples here, prostate cancer obviously, heavily dependent on testosterone to proliferate and divide. So we use what's called androgen deprivation therapy. Essentially, it chemically castrates you. Okay, so obviously, a man, their testes does not produce testosterone anymore. So therefore, in turn, cancer can't utilise that testosterone. Right? Same thing with breast cancer though, depending if, they're estrogen or progesterone positive, they'll use types of drugs like tamoxifen and letrozole, again, just to try and reduce those hormones being produced and reducing that ability for that cancer, so to speak, to grow as well. Hormone side effects, again, it depends on the specific treatment itself. The different type of drugs they use, as we all know with medications, they have their side effects and they have their benefits. So it really just depends on which one what they're utilising. The big things here, mood, emotional stress, sexual dysfunction. So this is when, your partners and loved ones start coming into the frame here as well. Okay. Obviously, at this point in time, we still like to have our loved ones. We still like to have, things, sexual intercourse, things like that. So obviously, if you're not able to do these things, it's really starting to affect someone's quality of life as well. And that's simply by just taking some hormone therapy. Okay. Big thing as well, men, testosterone. Okay, we need testosterone to build muscle mass. Okay. If we're chemically castrating ourselves, muscle mass is going to increases that fat tissue as well. Okay, obviously, therefore, in turn, bone density and osteoporosis is another big thing that starts to increase as well, or the risk of it. Now, specifically chosen to talk about three major things which I think are going to be important to us as exercise professionals, but in general itself, doesn't matter who we are. Lymphedema is a huge thing here, as you can see. Essentially, what it is, it's that abnormal accumulation of that protein-rich fluid in a part of the body. Now, caused by that disruption due to the lymphatic system, due to surgery, radiation, or the cancer itself. So very common here. Someone might have some cancer in the breast, cancer around, their prostate, melanomas, things like that. Generally, what an oncologist will want to do is check the lymph nodes to see if it's spread there. Okay, so obviously at that point they will dissect the lymph nodes. Some of them they might actually remove altogether. So obviously, if you don't have those lymph nodes anymore, there's a disruption in that lymphatic system, and obviously, therefore, in turn, that protein-rich fluid accumulates. And as you can see, there's different stages here. Stage 4, quite significant accumulation. Different studies have shown, though, however, aerobic and resistance training does not contribute to increased edema. Right? Very, very important. Can actually assist with this. Gold standard at the moment is complete decongestant therapy. So essentially what that is, compression, manual drainage, exercise, keeping active, things like that. Okay, that's obviously more of the OT type of analogy here, but obviously lymphedema specialists, physiotherapists, obviously do this as well. Now, here's where it gets very interesting for us. Cardiotoxicity. Okay, research is suggesting that cardiovascular disease deaths. I'll just flip this out about right. Yep, right there. It's very common in cancer patients undergoing treatment. Okay. Cardiotoxicity, 1 in 10 patients do not die from their cancer, but from heart and blood vessel problems themselves. Yeah, so huge, yeah. Okay. If you're diagnosed before the age of 55, the risk of death from cardiovascular disease is increased tenfold. So as you can see here, really cardiotoxicity is due to the treatment itself, chemotherapy. So as we've spoken about, it doesn't just target those cancer cells. Unfortunately, it targets the healthy cells as well. So essentially what happens is, cardiac myome, the tissue, all that sort of stuff, it gets damaged as well, becomes toxic, and obviously then precursors you to different comorbidities up there as well. Interesting enough, pre-existing cardiovascular disease and age-related changes can overlap and consequently increases a patient's morbidity. So obviously if someone isn't exactly the healthiest leading into their treatment, obviously the risk of cardiovascular disease and cardiotoxicity is therefore increased. So this is where that prehab starts to come into it a lot more, educating the patient early on in the piece and trying to get them started with exercise as soon as possible. The healthier and the more functional reserve we can have for someone, the better it's going to be. So obviously when you're doing an assessment on someone that's started treatment, it's very important that we undergo baseline testings, echoes, ECGs, just to get a bit of a baseline as to where you're at. However, this should obviously then be reassessed 6 to 12 months down the track. We're talking even sometimes 5, 10 plus years as well. Sometimes that toxicity isn't going to be, the effects aren't going to be seen potentially years after the treatment itself. Early detection and intervention is key, as we've just discussed. Assessments and things like that. Diagnostic cardiography as well. Okay, chemotherapy-induced peripheral neuropathy. This is another big one for us. So, 60% of cancer survivors will develop CIPN from neurotoxic chemotherapies, taxanes, platinum-based agents, and vinca alkaloids. So, there's 3 things that I spoke about there before that would be worth noting. So in reality, they don't actually know what causes the actual CIPN itself. I think it's something to do with the mitochondria and obviously the sensory nerves. But essentially, it's the damage to those nerves: sensory, motor, autonomic. All right. So symptoms, which I'm sure we're all aware of: classic tingling, numbness, burning pain, weakness. But a big one for us: loss of proprioception. All right. So these type of patients, they're an extremely high falls risk. Okay, so obviously how that affects us in our treatment, obviously balancing type exercises. We want to make sure that someone's confident with their balance, confident with their gait. Therefore, in turn, we're building their confidence as well. The last thing we want to do is, get them out for a huge big walk. They can't feel their feet. They come and go, all of a sudden they're, fractured hip. Obviously not the cold, it's right? So if we can prevent that from happening, obviously that's the key. Okay. So this can develop actually within weeks, during the treatment, months after the treatment, even years after the treatment. So this is this toxicity we're talking about still. No effective cures, as we know. However, exercise can help us. As we just mentioned, the more and more that we can try and implement balance and functional exercises, the better someone is going to be. Cancer-related fatigue. I'm sure we've heard all this from anyone that you've ever had any contact with cancer. Fatigue is the most common and distressing side effect of cancer treatment. Okay, so as it's defined here, distressing, persistent, subjective sense, physical, emotional, cognitive tiredness. Okay, it's not relieved by rest. It's not proportionate to the activity that they do. It's just that constant feeling of being wiped out. Okay. As you can see here, in a meta-analysis indicated 50% of breast cancer survivors were affected and can persist up to 5 years post-treatment. Okay? So us as exercise professionals, what we can do, as I mentioned, it's aerobic resistance type training. All right? If we can, again, work within their range, work within their limits, as they tolerate it day to day, week to week, we can try and help build up their functional reserve and obviously build up their cardiovascular fitness, therefore in turn hopefully reducing the side effects of fatigue or the severity of fatigue as well. We get into the current oncology guidelines. Now, those of us as exercise physiologists, EPA obviously is our governing board. Okay, they have our recommendations as to what they think that we should do in terms of exercise. Another classic one here is the ACSM. Okay, obviously they're a huge big board over in America. All right, both of them have come back after big roundtable meetings. Okay, now analysing all these different studies. And they've come to the conclusion that 150 minutes of moderate intensity exercise a week, 75 minutes of vigorous is the key. Now, this is aerobic activity. Okay, so essentially what that is, aerobic, as we know, heart rate, elevating the heart rate, getting us puffing, all right, activating our cardiovascular system, all right? So, difference between moderate and vigorous, of course, us exercise professionals know, but just for anyone else out there, moderate, yeah, probably about 65 to 75% of your heart rate reserve or heart rate max. So, it might be a case of a brisk walk, get you slightly puffed, but you're able to hold conversation, all right? Difference between that and vigorous is that half and puff exercise, right? So, it might be a case of running, going up, walking up hills, swimming, bike riding, that's pretty substantial as well. Anything that's real half and puff, okay? We then obviously want to work on your strength and conditioning as well. So, resistance training 2 to 3 times a week. Okay, as we'll come to talk about a little bit later here, cancer cachexia, however you want to pronounce that. Essentially, it's just weight loss that's essentially to do with cancer itself. You're not wanting to lose weight, you just generally lose weight. Okay, so if we can prevent, that muscle mass decreasing by using strength training, that's hopefully going to reduce the severity that you're going to sustain. Big thing is it should be individually tailored and monitored. This is where you're going to get safe and effective results, obviously, for that patient. As we've just spoken about, aerobic exercise 3 to 5 times a week, moderate to vigorous. You monitor this really through your heart rate reserve, which essentially is the difference between your resting heart rate and the maximum heart rate. Another good thing, though, is the BORG, Radiant Perceived Exertion Scale. So, for those of you that don't know, essentially it's a big scale and it gives a whole list of numbers on the side of their perceived exertion. So, for instance, a 13, it might be a moderate intensity, so slightly short breath. 15, for instance, it might be up around that, I'm getting pretty breathless, okay? So particularly those of them that may be on, beta blockers because of heart complications, things like that, your heart rate may not be the only thing to go off when you're prescribing your exercise. So having someone's actual feedback of how they're working is very, very important. So for instance, you might be looking at someone's heart rate on a heart rate monitor, and might not be over 100 beats a minute, but they're sweating, red in the face, they're huffing and puffing. So you can sort of see that the heart rate isn't a true representation of how they feel. So that's why it's very important to go through both how they're feeling on a scale and obviously through their heart rates. Very, very important. Another key factor here is reevaluating the intensity weekly. Someone that's going through cancer therapy, 1 week they may be feeling okay, they can do vigorous activity. The next week they might be wiped out. They can do very, very little. Okay, so really it's just a case of, again, modifying that exercise as to how that patient's feeling at the day. Okay, obviously that's our bread and butter. It's a case of course, trying to work into a point where we want as much intensity as we can, but if they can't tolerate that and it's going to make their symptoms worse, just back it off as well. Very, very important. Resistance training, as we mentioned, increases muscle strength, maintains lean body mass. Key factor here. Loss of muscle mass, higher mortality rates. Simple as that. Okay. Obviously, if we can reduce treatment-related side effects and reduce the the cachexia that's occurring and the weight loss that's occurring, obviously someone's going to have a better outcome as well. FIT principle: frequency, intensity, time, and type. So as we know, essentially the frequency is the frequency of exercise. The intensity is the intensity we spoke about moderate and vigorous. Time, how long are you doing it for, and the type of exercise, right? Whether that be aerobic, bikes, treadmills, etc., or strength training in this instance here. So supervision is the key, obviously. A lot of these people that probably would not have been exposed to doing exercise in a very structured regime. So us as exercise professionals should really aim to supervise, make sure you're overseeing their training as well. And obviously when you're giving them things such as home exercise programs, making sure they're very comfortable with doing it and making sure that they're doing the exercise correctly as well. Obviously the big ticket items here, we want to use compound exercises. So essentially that's just exercise that uses multiple muscle groups at once. Right? So your big muscle movers, squats, sit stands, chest presses, things that are just going to focus on a bicep curl. Now we want the whole picture here, we want to strengthen the body, particularly when you've only got a short span of time to see these people. You want to try and get the best out of your session with as much as possible. 2 to 3 times a week, if possible. How do we assess cancer patient? Okay, an initial assessment. Again, this is really just exercise professionals ourselves, but I'll keep it very, very broad. Okay, this will go for GPs, you can use some of these things as well, OTs, any other element health essentially. So you want to do a subjective and an objective assessment. So obviously big ticket items here, you want their current treatment regime, what they're going through, what sort of chemo they're on, how long is it for, the type of agent they're using, all these type of things. You want to know that down to a T as much as possible, all right? Questionnaires are a pretty big thing as well to give us some good information. I've just put a few ones in here. So the fatigue severity scale is a really good one. Obviously, as we mentioned, fatigue is probably the number one symptom someone will experience. So that just gives us a bit of an update, in your assessment, how that fatigue. It just gives us a bit more information, what particular environments or what particular activities are causing fatigue, things like that. The facet F, functional assessment of chronic illness therapy, fatigue, again, just a bit more elaborate than the fatigue severity scale. But other things such as, your functional assessment of cancer therapy, physical activity questionnaires, just gives you a bit of an idea of their baseline, how much exercise they've been doing leading up to this, and their conditioning as well. And of course, you can use any other one of your clinical judgment as well. And that's why we have clinicians at the end of the day. Big thing as well is SMART goals. Okay, I'm sure as we all know, going through university, SMART goals are drilled into us all the time. But it's very, very true. You want goals that are specific to that particular patient. There's no point trying to get 80-year-old little Betty, out walking 5 kilometres in the hot sun, after she's just gone through intense chemotherapy or something like that. It might just be a case of keeping her functional to do her ADLs, activities of daily living around her house. For someone that's a little bit younger, 4-year-old lady with breast cancer, yeah, she was quite active previously at the gym. She was training for marathons, things like that. So it might be a case of building up her goals for a little bit more of a specific intensity as well. So it really just depends on the person, and the more specific you can make it to them, obviously the better the outcome's going to be too. The objective outcome measures, now, these are pretty stock standard for exercise professionals, but I'll just give us a quick rundown of what they actually are used for those of you that may not be familiar. 6-minute walk test is a classic, assesses someone's cardiovascular fitness. As we've already mentioned, cardiotoxicity, fatigue, things like that, very, very important to know. Range of motion testing, those are the people that have had, breast cancer, they've had, colon resections, things like that. We want to make sure you're getting a baseline function and a baseline range of motion testing to see how well their limbs are moving. Okay, timed up and go. Essentially, that is a test to see somebody's function. It's up from a chair around a marker, sitting back down. The longer the time it takes, the more chance that they have a falls risk, and obviously the more frail they may be as well. Okay, 30-second sit to stand, grip strength and push-up tests. Pretty self-explanatory here. Measures the strength of our leg muscles, our upper body, and our grip. Again, very good identifiers of strength. Balance is a key here as well, particularly those people that may be suffering from neuropathy, chemotherapy-induced peripheral neuropathy. Assessing someone's balance is going to give you some good indicators to know how much they can tolerate in a session and how safe they might be. So obviously, if somebody has significant CIPN, you're not going to get them over, on the treadmill without holding on or something like that. You're not going to put them over with a high-level balance exercise with no rails next to them. So again, this all really just helps you determine your prescription. Very, very important. All right. Barriers to exercise itself. So obviously, some challenges here. The patient has deteriorated. It's cancer after all, we provide the treatment itself, chemotherapy, radiation. They do deteriorate. It's as simple as that. Hospital admissions, they've got multiple medical appointments, oncologists, they're seeing yourself, or exercise physiologists, you're seeing psychologists, occupational therapists. So sometimes it can be very, very hard to fit in all these things, okay? And then, of course, they'll change in their clinical presentation day to day, week to week. Financial and health fund restrictions to attend. Again, we provide a good service, we should all be proud of that. But of course, it costs money to do that. And if someone's seeing 4 or 5 different therapists, this adds up, particularly if someone doesn't have private health cover, and obviously a good source of income as well. And a very key one here as well is lack of awareness as well. So, oncologists themselves, sometimes there might just be a bit of a lack of, that referral basis to us and allied health professionals. I mean, obviously, we want to make sure that, the treatment regime and, all that stuff is sorted first and foremost. But I think the lacking of awareness as to us as exercise and allied health professionals is definitely something that needs to be made more aware, particularly with some specialists. If they can work in with us, that's what's going to give the patient the best outcome. All right. Positives though, we can utilise group environment, that camaraderie, obviously someone that's going through that they can relate to, improves the motivation, and then obviously helps with multiple avenues of support as well. Considerations and precautions. This is before we start exercising itself. Obviously, any medical screening and clearance is required. So by oncologists, the oncology nurses, obviously your assessment itself, you've got to make sure you pre-screen these people to make sure it's actually safe to do the exercise. Okay. Big things here, patients with metastatic cancer, comorbidities, assisted side effects, obviously they'll need a bit more close monitoring. So this is where you come back to being in touch with the oncologists, the oncology nurses, getting from their point of view, look, what's happening over here at the chemotherapy, how's that going to affect you? Okay. Obviously, patients will be immunocompromised at this point in time, neutropenia. Okay, so monitor your own health. Obviously, it's not a good idea if you're crook as going into an oncology rehab where these people are immunocompromised. Again, making sure that you're just aware of that as well. And cytotoxic agents can be excreted in bodily fluids 1 week post-treatment. So obviously with chemotherapy, they excrete it in their urine, their feces, things like that. So obviously when you're doing some exercise, if you're in a gym environment or if you're at your own practice, things like that, just make sure you're hygienic, wiping things down, double flushing toilets. Again, these cytotoxic agents are present, so you don't want to get them on yourself either. Now, these are very important. Cancer-specific precautions. Okay, so fix that away if you can here. That's all right. So, peripheral neuropathy, ataxia, as we've already mentioned, just making sure you're avoiding activities that's going to significantly compromise someone's balance if they're not ready for it. Do some exercise in some parallel bars. Make sure you're there supervising someone. The last thing you want to do is let them fall. Obviously, it's going to lead to a whole host of complications as well. Okay. Bone metastasis. Okay, the cancer has spread the bone. We'll touch on that a little bit further shortly. Avoiding movements that place excessive load on fragile skeletal sites. So, obviously, the big thing is you want to avoid any plyometrics. So, jumping up and down type movements, excessive loads on that particular joint site. So, for instance, if you're got some metastatic cancer in your back, you don't want to be getting someone lifting something heavy like this. You don't want them twisting, etc., etc. Fatigue and muscle weakness, exercise tolerance. Again, they will fluctuate day to day, week to week. Enostomy, so essentially someone that might have had, some sort of colon or gastro type cancer. Obviously, they may be on a colostomy bag, right? So obviously, when they're coming into exercise, colostomy bags on the outside now. It's always a good idea to empty that before you start exercise. I can attest to that. I can tell you. It's the last thing you want to do. Just let that leak out. Obviously, start nice and slow. Progress them as they tolerate it. You can also have access to, a protector or a shield if somebody's comfortable with that as well. Blood counts. This is another big thing. Obviously, with systemic chemotherapy, low HB levels. So obviously, this requires O2 transport. If it's very, very low, obviously you want to avoid activities that are high intensity at this point in time. White blood cells. Okay, obviously neutropenia. Avoid exercises with increased risk of infection. You don't want someone probably going to a public pool, things like that. Obviously, you're increasing their risk of infection, which again, they're immunocompromised at this point, right? And body temperature. Obviously, if they're over 38 degrees, and that probably goes for all of us as well, there might be some sort of infection present, so always monitor that. Obviously, refer to the appropriate people as need be. Okay. Now, just some quick blood count here. I'm not going to go into too much detail, but if someone is under 1,500 in their white blood cell count, that's considered neutropenia. So you want to have a symptom-based approach here. Okay. Again, just go by how they're presenting. Right. Anything over again about 4,000, you can start to increase the intensity a little bit more as well. Platelets. So anything less than 20,000 cells, this is where you're starting to think, okay, they may need some sort of transfusion. It's probably not the best idea to be doing some exercise at this point, so you should be in contact and referrals of an oncologist made as well. Anything over 20,000, start with some light exercise. Essentially, it's exercise tolerance. And as you go up to about 150,000, you can slowly start to increase their intensity as well. And last but not least, your hemoglobin as well. So normal values, 17 14 to 17 for males, 12 to 16 for females. So anything less than 8 males, anything less than 11, symptom limited, monitoring their progression. Obviously, they're getting down into that anemic type stage. And then anything less than 7 to 8, again, that should be very, very light exercise. Referrals made to the right people here as well. So, shortness of breath and nausea, again, exercise intolerance here. If it's persisting, particularly that nausea, they may have to review their current chemotherapy regime because they may need to change that up. Okay, sometimes chemotherapy, the side effects may be too much for a particular patient, so they will actually switch over a chemotherapy regime to still get the same effect, but again, hopefully not have as much side effects as well. So just something to keep in mind with nausea as well. Bone mets. Okay, this is a big thing we need to watch out for. So you can see here, essentially what it is cancer has spread to the bone. It'll be osteoblastic or osteolytic, so tumour grows over the bone, osteoblastic, osteolytic, the tumour eats into the bone itself. Okay. Obviously, the big thing for us as exercise professionals, the risk and susceptibility to a fracture. Okay. As you can see here on the right, which I'm sure Dr. Cole, you've probably seen maybe in your career. As you can see here, there's a metastatic tumour on the femur, just here. Whatever's happened here, they probably kind of fall, more than likely. Obviously, they fractured the femur. Now, very important to note here, actually, on this X-ray, that this lady has quite significant osteoarthritis in her hip joint, but they've chosen not to actually do a hip replacement itself because of that fracture. Okay. Ideally, if someone were not having metastatic cancer and they had a fall, little old lady, generally, depending on the person, they would do a total hip replacement, just replace the whole joint itself. Obviously, in this case, though, they've just put rods in the bones themselves to try and stabilise them. Okay. Common locations, as you can see there, but red flags, these are the big things we need to watch out for. Bone pain itself, particularly on weight bearing, and it's worse at night. Someone that has metastatic back cancer, laying flat will actually increase their pain quite significantly. Obviously, which I'm sure we've all dealt with back pain before, usually when someone's laying down, can be a bit of a relief for their symptoms. So if somebody's symptoms and pain is increasing at that point, that's when we need to start looking at, okay, further investigations need warranting. And obviously then pain itself, if someone has metastatic cancer, it's getting worse and worse and worse. Further investigations need to be put in place as well to investigate if it's spread even further. Exercising with a PICC line or a portacat. Now, obviously, someone might be on systemic chemotherapy for an extended period of time, weeks and months. Okay, so essentially what they will do is either use a PICC line or a portacat. That way, then that they're reducing stabbing risk and constant entry into the veins. All right. Big thing here as well. It reduces the risk of infection too, which is good. So a PICC line, use the chemo, taking the blood, obviously, to check all those neutrophils, given fluids, things like that. Little studies on the risk of exercise for this. Really the big thing is just consult a specialist and go by how the patient feels here. So obviously this is where you need to be in contact with the oncologist. Just making sure, I want to do some exercise with, Betty, for instance. Is it okay if we proceed with this, that, and that? And that'll help with, determining to move forward as well. Portacat, this particular one is an extended one. So essentially it's inserted under the skin and remains in place longer than the PICC line itself. So essentially this is just easy access to the major veins, so superior vena cava, all right? So essentially that treatment or that chemotherapy just gets injected straight into the vena cava there, and obviously then the heart pumps that out straight away instead of obviously down here on the arm, just to go all the way up, etc., etc. Obviously, the big thing is here though is a DVT risk is increased, so of course monitoring for those sort of signs and symptoms as well. Oncological emergencies. So, spinal cord compression, obviously increased levels of calcium, low levels of sodium, superior vena cava obstructions, all these things caused by the cancer progressing itself. Okay. Unfortunately, sometimes the treatment isn't always going to be, beat the cancer, etc., etc. But obviously, as it proliferates and it goes further and further and further, it can start to cause some more of these side effects as well. So the progression of the disease itself, treatment effects, and underlying comorbidities as well. So all these type of things are contributing to emergencies. This should be investigated ASAP. We're talking, emergency. Particularly here, spinal cord compression, as we can see here, this is a huge one. Now this comes back to the bone mass we were talking about in the spine. As you can see here, we've got a tumour, in the vertebrae itself. And as you can see here, as that tumour is starting to grow, it's compressing that spinal cord. Obviously, this is a big emergency at this point. People can obviously become paralysed because of this. So obviously, red flags you should be looking out for: any changes in their bowel and bladder movements, sensation losses, different changes in the gait, things like that. These are the sort of things you want to make sure you're looking out for. Very, very important. We're just going to finish here on a bit of a case study. I'll wrap this up fairly quickly here. Essentially, a lady I saw was a 24-year-old female diagnosed with Hodgkin's lymphoma. So essentially what that is, it's a significant number of white blood cells that aren't having that programmed cell death. They're continuing to proliferate, obviously, in the lymphatic system. And then obviously what in turn happens then is that spreads around the body through the lymphatics, and that can cause lesions in different parts of the body as well. So essentially, this lady, it was an incidental finding on a chest x-ray. So she works in the Navy, she had a bit of a boating accident, and then obviously after that, she needed to go through, the routine checks, things like that. They did a chest x-ray on her, and noticed one of her lymph nodes in her chest was enlarged quite significantly. Absolute telltale sign of Hodgkin's lymphoma. So obviously, once they've discovered that, she commenced 5 rounds of ABVD chemotherapy. This is just a classic chemo, 4 different drugs in one that they use for hematological cancer. She did this fortnightly. Side effects that she had were fatigue and nausea were the big ones. So at this point in time, as you can imagine, a 24-year-old lady that was fairly fit in the Navy, she's still experiencing these type of side effects. You can imagine what an elderly lady or gentleman would be experiencing. What she wanted to do was return to work. She wanted to get her muscular strength back, obviously, for her work-related duties in the Navy, heavy lifting, things like that. And she wanted to lose some weight as well. Okay? So in my subjective and objective assessment, obviously I assessed her cardiovascular fitness, assessed her strength, range of motion, even a bit of her balance, okay? Because she's on chemotherapy, as I mentioned, checking to see if she's got any sensation changes as well. All right? She was fairly fit, to be honest, at this point in time. However, she was a bit deconditioned. So essentially what I tried to aim for was to use moderate to vigorous aerobic exercise, 60 to say 85% of her heart rate max or reserve, and a lot of those bigger muscle groups, strength training exercises to build their muscles, right? So this lady discharged with us probably about a month ago, I would say, something like that. Significant improvements in all those factors. All right, she's back at work now. She's was on restricted duties, however, they're starting to increase. And obviously, her quality of life is getting back as well. Getting back to that normal quality. All right, so yeah, just a little cool case study there. So, in summary, right on time now. So, essentially, exercise intervention, it can be intervened or prescribed in any stage that somebody is in. Okay? Whether they're newly diagnosed at 24 years old or they're palliative at 80 years old, exercise has been proven to improve their quality of life, their baseline function, and obviously then reducing the burden that cancer has. All right. Obviously, us as exercise professionals, I definitely think there's an untapped market, particularly up here in the far north. So it's definitely something that we can hopefully look at providing a better service, working with oncologists, working with specialists, etc., to get those referrals in, and that way in turn we can really try and make a difference in these people's lives. Okay? Very, very key. Very good. Thank you very much.
So thank you.